Good morning, everybody. Thank you so much for showing up today for our grand rounds. We are going to get started in about 5 minutes, but certainly appreciate you being here early. So thank you for that. While we're just settling in, please feel free to introduce yourselves in the chat, who you are, where you're coming from, and we will get started at the top of the hour. Oh, it's nice we have someone from down south in St. Louis. Welcome, Kevin. Thank you for being here. I see someone here from Calor. Everyone else is just being very shy right now. Is that what's happening? But feel free to introduce yourselves in the chat while we're getting settled. It is it's definitely, I definitely feel very strongly that Monday, there's something about this Monday in particular too. Maybe it's after the holiday. It feels extremely Monday. So good point, Matthew. Hi, Barbara. Thanks for introducing yourself. We love our nurses. Ah, someone from Maryland. All right. We're moving out of the Midwest. Going national today. Thanks for being here. Hi, Audrey in accounting. So we all know where we are. So I'm going to stop sharing this screen for a second so we can see each other's beautiful faces, or those of us who are brave enough on this Monday morning to show it. Thanks all for being here. All right, Melvin and Springfield, welcome. Okay, it is the top of the hour and we have a little bit of logistics to go over. So I'm going to go back to sharing my screen and get the ball rolling for us today. Let's see, that's what I want. So if you are here for COVID-19 Grand Rounds, provider, personal, and public health perspectives on vaccine equity, you are in the right place. We have two amazing speakers, Drs. Janet Lynn and Dr. Terrance Weeden, who will be speaking shortly. We look forward to their comments and your questions and participation in this discussion. This is my reminder to push record because this is something I typically forget to do. Oh wait, I actually already am recording. Okay, I've been recording. Very good for me to remember that. So it is going to be recorded. Remaining on the Zoom means you are consenting to the recording. We'll send you a link afterwards. So everyone who's registered here today will get a link. We'll be also putting it up on our website so you can visit these materials and previous materials as well at aidchicago.org/COVID Grand Rounds. Please do drop your questions and comments in the chat. I'll be monitoring that chat and make sure that both of our speakers hear your questions or your comments. We're also really open to you using your camera and commenting verbally when the time comes, so feel free to do that as well. It's always nice to hear and see people's voices. And we are offering continuing education credits, and I'm gonna have my colleague and partner in crime explain that in a second. I wanna also thank my colleague and partner in crime, Shanette at MATEC, and MATEC for helping to support this. And also I wanna give a shout out to Humana for helping make this particular COVID Grand Rounds happen. And Shanette, would you like to come on and tell us what we need to know about continuing education credits?
Yes, happy Monday, everyone, on this gloomy Chicago Monday morning. Hopefully the rain showers haven't hit you yet. So yes, Maytech, we are happy to support webinars as such. Love to be in partnership with AFC as well as Humana. We will be sponsoring CEs for this webinar. So please know up until July, all of Maytech CEs are free, which is so awesome. For this webinar, it is 1.0 hours of continuing education credits for social work, nurses, as well as we have universal credits. Towards the end of this webinar, particularly in about 15 minutes prior to the end of the webinar, I will be posting the evaluation link. In order to receive CE credits, you must complete the evaluation. Complete the evaluation, and during the evaluation, you will have the option to select if you would like continuing education credits, and specifically what kind. Did you like nursing, universal credits, or social work? The evaluation will be open until Friday, April 9th in order for you to claim your CE credit. So please complete it at that time. If you are unable to access the evaluation today, it will be in your Maytech participant dashboard where you can complete that evaluation. For all other inquiries, please email us at maytechillinois@uic.edu. And that's it. Thank you, Jim.
Thank you, Shanette. And thank you for providing CEs to our participants. It's awesome. So I actually want to highlight our next Grand Rounds. This is coming up on April 27th. We have a panel from the Chicago Department of Public Health who's going to be talking about the full sort of Chicago response to COVID. We're not well over, but a little over a year into our response. And they're going to be sharing a number of learnings and perspectives, and it should be a really interesting talk. So that is Tuesday, April 27th from 1 to 2, and you can see the URL for registering there, and we'll drop that into the chat in a little bit, so you can just click there if you want to. And so I'm going to stop sharing here. And without further ado, I am going to introduce our first speaker today, who is Dr. Janet Lynn. from the University of Illinois, Chicago. She is a multi-hyphenate. If I was to go through everything and every hyphen that she has, we would be spending most of our time introducing her. So I'm going to let her share the hyphens she would like to and kick us off, and we will be followed afterwards by Dr. Terrance Weeden from Lurie Adolescent Medicine. Thank you both so much for being here, and Janet, it's all yours.
I am just going to confirm that you are actually seeing my screen as normal screen.
Yep, it looks beautiful. Thank you.
Perfect. Okay. So thank you, Jim. Thank you, Shanette. Thank you, AFC and MATEC, in regards to allowing me to share some of our perspectives and maybe some of my personal perspectives in regard to thinking about COVID vaccination and the role of community engagement in a university setting that's helping to participate in ensuring that Chicagoland neighborhoods are vaccinated. And so, as Jim said, my name is Janet Lynn. I am an emergency physician by training and practice, but I hold a couple different hats, both as a faculty member in the College of Medicine, as well as the School of Public Health. And for this specifically, I'm functioning as the operational lead for our UI Health implementation of Protect Chicago Plus and some of our community vaccination efforts. So I think these are the requisite slides in regards to a disclaimer in regard to MATEC and this program specifically. I do have a couple financial disclosures in regard to receiving funding for HIV work, both from CDPH as well as from Gilead, related to testing linkage to care. So just hopefully in the next few minutes, you know, for my portion before we move towards Terrance and talking about some of the other equity aspects, what I wanted to try to do was frame kind of our discussion and share some of our experiences in this. So really discuss, you know, the relation of UI Health's overall mission to protect Chicago Plus, and then describe kind of what our strategy and model for implementation of these temporary clinics as specified by the city of Chicago, and how we've been able to achieve this. And then I think most importantly is really reinforcing the importance of these community embedded approaches to achieve vaccine equity, which in and of itself is not necessarily a simple task, but I think something that we are very much committed to. So I think as the title actually suggests, I think health equity kind of supersedes all of the approach in which we're actually looking at this. Not only from just UI Health's overall mission, if we look at it from our hospital perspective in terms of our care that we aim to provide, but then also, you know, not the focus of this, but even our own COVID experience in regards to the care. And then of course, now thinking about vaccine distribution. So I didn't bring necessarily our health mission per se, but it has, you know, within that promoting health equity in the care that we provide. But I think importantly, especially as we've gone through our COVID response experience, and as we move towards kind of a COVID prevention aspect, you know, one thing I reflect upon is really UI Health's care. Really thinking about, you know, providing compassionate care to better understand and respond to our people and our needs, to be accountable, to be able to act ethically and responsibly in everything that we do, and to respect all of the different relationships as well as the communities in which we serve. And then, you know, to provide the highest quality care and continuously improve. So of course, even our efforts in regards to community COVID vaccination is not static, but it actually has been evolving over time, and especially within the different neighborhoods in which we've actually had an impact. So for those of you that may or may not be familiar with the Protect Chicago Plus program, this is really the city's effort and program to really promote equitable distribution of vaccine. And so one approach that they took was to really look at the community vulnerability index related to COVID and Chicago, and looked at where the hardest hit neighborhoods were and measured it from a social vulnerability perspective. So you can see kind of in the background are the 15 neighborhoods that the city of Chicago had identified as the hardest hit in regards to COVID, but also served to be really the platform on which to promote and try to ensure that vaccination got to these neighborhoods. And the aim of it really was to really bring these most affected neighborhoods, as well as the vulnerable neighborhoods, to a par level that's commensurate with really what the city's vaccination rate is. And the next slide that I'm showing is really data as of last week to kind of see overall Chicago week ending, March 20th was close to 22% of the city was vaccinated. And when you actually look at these different neighborhoods, the 15 neighborhoods within Protect Chicago Plus, you can see where it started, but also where it's at week ending in 3/20. I've highlighted the areas where UI Health is actually specifically involved. And you can see there's different areas where there's been multiple different waves of dedicated vaccination campaigns going on, where that percent increase is definitely occurring. Where Illinois and UI Health have had presence is actually in these 4 different neighborhoods. So our community vaccination efforts were really intended to tap into not necessarily creating something new, but leveraging our existing relationships within these neighborhoods. And so how our approach was in regards to looking at these areas and saying that we had a role to play was looking at our FQHCs, our federally qualified health centers, of which there are 12 different clinics, but 7 actually standalone ones within these neighborhoods that included Englewood, Back of the Yards, Humboldt Park in the Chicagoland area. And so coupled and paired our mile square FQHCs with these vaccine areas. And so we've been able to really look at how do we actually leverage the already embedded infrastructure to ensure that these communities had access to vaccination. So one of the things, even despite the fact that there was presence already, that's, I think, one important component is to have an already present a presence already within the community. But I think the other aspect of this was a commitment to not only just be a dedicated vaccine, but also thinking about the ongoing care that's actually required. And so what we've been able to do is through the Mile Square centers, but also through our University Community Care Network, which is actually a HIV care network, been able to actually deliver dedicated vaccines through the Protect Chicago Plus program. I think when we start thinking about some of the equity issues, I think there's 2 buckets in which you can actually divide kind of the challenges of implementation of this type of effort. One, if we actually sit and reflect, we officially found out that we were actually going to be hosting these clinics about a week prior to the initial start, which was March 1. So in order to think about, what are the challenges of implementation, I think there's a couple different ways in which you can look at it. One is just from the clinical operations perspective. How are you able to bring up a mass vaccination effort in a really short amount of time and ensure that it actually is nimble, it's integrated within a system, it's streamlined so that it does not essentially stop the normal clinical function, but then also adheres to the community service mission that that Mile Square holds. The other side of it is how do we actually get people identified? The Protect Chicago Plus is a little bit different than the phased approach for vaccination overall, in that in these neighborhoods, all people 18 years and above are eligible for the vaccine. So they do not necessarily have to abide by the phases, but any person who resides within those neighborhoods has access to this vaccine. Now, it's defined as phases, but I think the other challenge is then how do you actually leverage the existing relationships and how do I find the people that actually live in these neighborhoods so that they know that they're actually getting it? And so access becomes a really big and important component of our community vaccine efforts and making sure that we're leveraging that. I think couple things that were challenges. I think representation, despite the fact that the city identified these 15 neighborhoods, there are, conversations that actually occurred pre and even today that, people don't necessarily feel like is this the correct representation? Are there people that are being excluded? And so I think there's a big need to make sure whatever efforts that are being done, it's being done in a mechanism that's trying to be as equitable as possible. I think and also to be as fair as possible. You don't want to unnecessarily alienate any one particular group of people, but you want to make sure that it's actually fair and open to any person that wants it. The other thing too is being responsive to the needs. Just because you have vaccine available does not necessarily mean that that's actually responding to what the needs of the neighborhood is. And I think very clearly we wanted something, and people in the neighborhood wanted something that was very easy to use and to be able to register, and also transparent. I think there's a lot of mystification that actually occurs in terms of how people are getting vaccine, who has access to the vaccine. And it's extremely important for us to make sure that our processes that we put in place to get people vaccinated in the community were as transparent as possible. And I think the only reason why we're able to do this is the fact that we actually worked with our CBOs. So not only from connections from the city, but independent connections. As an example, for Englewood, there are no less than 30 plus organizations that reside within the community with whom I had personal conversations with to actually get them, understand that we were available and we were opening up a clinic, but then also to try to identify what were the needs that they had in order to get their neighbors, their constituents, their members in. And I think, once we actually implemented it, one of the challenges was then looking at, and what's ongoing now, is this distinction. We hear a lot about vaccine hesitancy, but I think it begs the question is it vaccine hesitancy, or is it a question about vaccine access? And, many people, like to kind of utilize vaccine hesitancy as a blanket statement and think that's the root of poor vaccine uptake. But I think you have to go deeper. And I really, what is actually going on in each neighborhood? In our experience, what we've seen is that every single one of these neighborhoods that we've actually had presence, it's very unique. I mean, there are some things that are common, but I think in terms of the approach and who actually comes out and who is willing to be vaccinated and who is not, is by no means a universal or one size fits all. And so I think we have to think about what are the people thinking within these communities. For some, it may be about the history that they've experienced up to this point, whether it's vaccine related, whether it's healthcare access related, whether it's the people that they interact with. The other is actually trust in the communities and the organizations that are there. The other side of it is actually thinking about awareness. It's not necessarily, when we talk about vaccine hesitancy, just about anti-vax. There are many people, even within these neighborhoods, personal conversations, some people really just want to wait and see. It's not to say that they don't want the vaccine, but they aren't sure themselves. And this is even not just across populations of people, but within families as well. I mean, I've had several conversations where, you may have a family of 5. 1 out of the 5 family members has been vaccinated, and it's not for lack of effort for trying to get the rest of the family members, interested in getting vaccinated. And then I think it becomes a question of, is it about human capability or is it about capacity? And what I mean by this is the capability aspect is people just don't know how to get access. Meaning, is there a digital divide? Are we looking at different populations of people that have very different kind of access points? Or is it because they just don't have the means to, because of a mobility issue, because of a disability of any sort? And so that's one side of things. But then is it also about the capacity? Do they even know where to look, or is it even about understanding the vaccine? And so when we start talking about the question of vaccine hesitancy versus access, I think we really need to think about, what is actually at play here. And it's not to say it's one or none, but it's probably all of the above. And we have to think about those implications, especially when we think about the delivery of vaccine, and especially within a health equity lens. And then as we move forward, as we think about the future of COVID vaccination, right now, especially with a Protect Chicago Plus, it is a dedicated effort. As mentioned early on, it's a dedicated effort to really try to bring some of the most vulnerable and the hardest hit locations at a par level. So, the city looks much more equitable. But, is that going to be sufficient, or is that going to be the only way? At what point does COVID vaccination need to be integrated into the normal workflows or clinical workflows of organizations, of clinics, of hospitals? And then, of course, it begs the question, for how long and for how much do we need to do this for? And I think the other question that is being raised is, are there models that we can actually adapt, whether it's from our current practice in regards to immunizations in general, or from history? And there's other things that we have to think about. Is this vaccine, or even COVID itself, going to be more like flu, where you're going to require a yearly vaccination, or is it going to be more like measles, where potentially boosters may be available, or it's a one-time only shot? And so we have to think about that within that lens, and how are we going to ensure that the people that need it the most get it? And I think one final thing, as I think about with the work that I've done with HIV, what are the parallels to HIV? I think early on with COVID in general, in regards to the infection, there are lots of questions, and people identify the stigma associated with COVID. But I think as we move forward and thinking about the work that's been done in regards to HIV prevention and treatment, what are the approaches that we've used to address equity and access, and what are the different delivery models that we might be able to leverage? Is it community health workers? Is it thinking about health promotion? I think regardless, ultimately, it's going to have to think about some sort of multi-dimensional model in which to think about this. And this may be the opportunity to think about, what have we learned in regards to our fight for ending HIV? What can we actually adapt into COVID itself? I think I'm going to end there, and hopefully at least be more provocative in regards to the presentation, as opposed to having, quote, the answers.
Thank you so much, Janet. That was a really great talk and much appreciated. We're going to take a moment to see if there are any clarifying questions or anything people want to bring forward to Janet. And Janet, if you wouldn't mind to stop sharing your screen, we can see folks. Are there any questions that people would like to share at the moment? Otherwise, we can have a full discussion once Terrance is done. Oh, there is something that just came up in the chat. He's talking about please describe how to provide equity without universal access.
I think that's a hard question to answer. I think this probably can apply to a lot of different health related realms. So I don't, I'm going to probably try to answer this through, the experiences to date in regards to COVID vaccination. I think the approaches that the city has taken, really trying to think about it from, the CCVI, which is really that COVID community vulnerability index. And so, one thing is, being able to map out where are, some of the utilize the data to identify, where are there disparities, where is there difference. And then I think the other aspect of this is thinking about then when we know that the demand right now is much greater than the supply. The supply is increasing. So we don't have, to your point, universal availability of vaccine, not just access per se. I think we have to think about it in these targeted approaches. I think that's the Protect Chicago Plus approach right now, is how do we actually focus our efforts so that when we think about equity, it's not that every single location gets the same amount of vaccine, but what is actually needed to actually ensure that the proportion of the population that is vaccinated or has access to the vaccination gets it. And that's really where Protect Chicago Plus has actually dedicated. The way they approached it initially was to say early on, if we want to get, there's definitely the uptake in terms of vaccine early on when you saw it. There are centralized locations of where vaccine got distributed to. And you could see where those gaps were. What the city's approach was in these targeted neighborhoods is very on a objective level was how much vaccine will we need to provide to get that neighborhood's population up to 10%. We've exceeded the 10% right now, but I mean, I think that was the first pass. When 10% was, Chicago, broader Chicagoland's vaccination rate, these areas that had 2%, 3% penetration, what is it going to take to get 10% of that population vaccinated, and then identifying partners to actually deliver that vaccine in those neighborhoods specifically. So that's probably the best way. You have to do it in a targeted way, but eventually I think if you want to integrate it, it has to be integrated into the health system.
Thank you, Janet. And we're gonna throw you one more question, and then we're gonna turn it over to Dr. Terrance. But what methods do you know about that are used to combat vaccine myths or misinformation? This person has just talked about the incredible amount of, information that's coming from cable news. It's a tsunami, basically, of information and misinformation all the time through cable, social media. So what are some methods that you know about to combat myths and misinformation?
I think first of all, it's going to have to be multi-pronged. So I think it has to be at multiple levels. There's not going to be one single strategy or methodology in which we're going to be able to address vaccine transparency. But I think most importantly is identifying credible and trusted messengers. I think where people, and it's having those conversations, and it's going to be different in different neighborhoods. I think in some locations that we've been, that one-on-one conversation, when they feel comfortable to ask some of the questions and feel comfortable to share some of their reasons or rationale as to why they either want to wait or are scared or don't want the vaccine, to have that conversation is extremely important. The other is having, being consistent in the messaging is the other aspect, especially when you're talking about transparency. There's lots of talks in terms of things about people thinking that people are getting discriminated against. And I think being consistent is going to be important, although that's not always going to be the case. But I think that's as much as you can maintain that and be consistent within the messaging is going to be another important component.
Thank you so much, Janet. And again, great talk. And we'll look forward to more conversation at the end. So I'm going to now ask Terrance to share his screen and go ahead and get started.
All righty. Can everyone see my screen okay?
It's looking good. Yes, perfect. Thank you.
All right, awesome. Good morning to those in the Central Time Zone, and good afternoon to those in the Eastern Time Zone. I'm grateful to have been invited to this talk to share not only my experience, but also just some historical context about vaccination hesitancy. And I want to preface this by saying, yes, vaccination hesitancy is still a problem, but also vaccination access is also a problem as well, which Janet here has already talked about. And my presentation is entitled Exploring COVID-19 Vaccination Hesitancy Among Communities of Color. I am Terrance Weeden. I am an adolescent medicine fellow at Lurie Children's Hospital of Chicago. I'm also an associate board member of AFC and also an executive board member of the Chicago Black Gay Men's Caucus. This is a disclaimer. I have no financial disclosures. And the learning objectives, as I mentioned before, is exploring the historical context behind some reasons that medical mistrust is still present and affecting minorities. We'll also be discussing the impact that COVID-19 has on communities of color, and also some common misperceptions about the COVID-19 vaccine. And then I'll actually share my own experience with my own hesitancy towards the COVID-19 vaccine. Here's a repeat slide and another repeat slide. So we'll just jump right in. I want to preface that some of these discussions may be a bit difficult, and some of the pictures may be a little bit graphic. But I want to start off by going back to history, particularly with slavery. I mean, a lot of people don't know this, but there were a lot of medical experiments performed on slaves unwillingly. We have most famously Anarcha Westcott. She was a slave in Alabama, suffered a lot of problems during childbirth, and eventually had to undergo several different experimental surgical procedures, both without consent and also without anesthesia. And this was performed by the father of modern gynecology, Dr. Marion Sims. And this medical experimentation was not just on Anarcha Westcott, it was on multiple female slaves during that time. Skipping forward to Henrietta Lacks. Henrietta Lacks was another Black woman, descendants of slaves. She was a tobacco farmer in Virginia. She was diagnosed with cervical cancer and received chemotherapy at Johns Hopkins. This was around the 1940s, 1950s. But 9 months after her initial diagnosis of cervical cancer, she died. But without her consent, even without her family's consent, the cells from her cervical cancer were biopsied and harvested. And they were cultured and used for scientific medical research. Despite this lack of consent and lack of knowledge that the family had about using her cells from her cancer, cervical cancer, we have benefited from those cells. Those cells from her cancer have been used in not only AIDS research, but also cancer research, and also the development of polio vaccinations. And most famously, we have the Tuskegee study, or the Tuskegee syphilis experiment. This was a 40-year study done in about 600 Black sharecroppers in Tuskegee, Alabama. Again, this was a study performed by the CDC and also the Public Health Service. These sharecroppers were promised free health care. They never received it. They were never informed of their diagnosis of syphilis. They were never told that they would not receive treatment, and they were never treated. Over 100 men died. Families were also affected, and 19 children were actually born with congenital syphilis. Finally, around 1972, there was a whistleblower who leaked some information to the Associated Press, which eventually stopped the study. But because of that came about, if those of you are familiar in the medical world or in the research world, this kind of prompted the requirement of IRBs, or institutional review boards, that require that any research involving humans, it requires consent. And now moving towards the Native American community. I'm sorry, this picture is a little bit graphic, but just wanted to get the full extent that Native Americans have been affected by many communicable diseases in the past. Diphtheria, measles, smallpox, which is probably the deadliest, as well as malaria and scarlet fever. On average, one Native American tribe lost up to half of its tribe members just from smallpox. And basically, English settlers brought these communicable diseases to these communities and basically decimated lots of different tribes across the country. And then we move to the Trail of Tears. A lot of people don't realize the Trail of Tears can be associated or described as genocide in a sense. There was an enforced removal of over 100,000 Native Americans and slaves from their homelands. And during that removal, thousands of Native Americans died of malnutrition, measles, malaria, and were not treated. And then we go to present day, where we talk about some medical mistrusts as it pertains to refugees and immigrants. There was a study done back in 2015 that looked at a lot of barriers to healthcare for refugees and immigrants. And those barriers would be language barriers, also the fear of being deported or being detained, lots of anti-immigration laws, physicians and doctors and other healthcare professionals who have implicit bias toward these communities, the lack of knowledge of refugees and immigrants, basically about the healthcare system, about knowing their own patient rights. And all this to say is basically these barriers can lead to poor health outcomes. Lots of children are not being vaccinated. Lots of mental illnesses are not being treated. Lots of chronic diseases are not being treated as well and can lead to poor health outcomes. So now I want to talk about the impact that COVID-19 has on the people of color, specifically life expectancy. Again, the CDC just recently released that the life expectancy decreased for Americans in the first half of 2020, but disproportionately, the life expectancy affected, the decrease in life expectancy affected both Black and Hispanic males. Black males, their decrease in life expectancy was almost up to 3 years. Hispanic males, their life expectancy decreased to at least 2 years, as opposed to Caucasian men and women whose life expectancy only decreased by a year. Of course, there were other factors that played a role in the decrease in life expectancy, that being cancer and also drug overdoses. But as you can see, COVID-19 disproportionately affected communities of color, and especially as you see at the bottom right of the slide, kind of a picture of how it affected Chicago in generally. The Black population, 68% of deaths from COVID were from the Black community. 10% of deaths were affected by or seen in the Latino community. I know this is a busy slide here, but this slide is serving to say that the impact of COVID-19 had different effects, not just on life expectancy, but also financially and also on mental health. The top left slide is showing that the unemployment rates for Hispanics, Latinos, Blacks, and also in Asians was significantly higher than those in the Caucasian community. The graph on the right is a study done in New York at the beginning of COVID, looking at the mental well-being of the communities in color and also Caucasian communities, and how, as you can see, depression and anxiety highly affected those communities of color. And again, on the bottom left slide, this picture is showing that communities of color suffered a lot of economic hardship compared to those of the Caucasian community. So this slide, so there's 3 different pictures here. The point is I wanted to kind of mirror basically that in the first picture, we have not just the lack of vaccine access to talk about, but also other issues to talk about as well, as far as food deserts, pharmacy deserts, food insecurities, and how these are affecting the south and west sides of Chicago. And that kind of also mirrors some of the deaths and the lack of vaccinations that are also seen in the south and west sides of Chicago. So there are multiple issues at hand. It's not just Tuskegee, it's not just slavery, it's not just the things in the past, but there are some things here in the present that need to be addressed that can also help us move toward vaccine equity. And this statement here is, our knowledge of the past can help us change the present and actually help us make an impact on the future. So now I want to talk about some of the common misperceptions about COVID-19 vaccines. So Kaiser Family Foundation has an ongoing study basically seeing that at first, Black and Hispanic adults had a lot of concerns about the vaccine, as you can see at the top right slide. But in the bottom right slide, a lot of the initial hesitation among the communities of color have actually dissolved, whether that is because of increased vaccinations or increased access to vaccines. We don't really know, but a lot of that vaccination hesitancy, a lot of that wait and see approach that Janet had mentioned earlier is slowly eroding away, which is a good sign. So these are some common statements that either I've heard or some other people have heard. COVID-19 vaccine will not give you the COVID-19 virus. The vaccines are actually designed to help us not only recognize the virus, but also fight against the virus. And there's another statement here. I already had COVID-19. I don't need the vaccination. You actually do, because it is rare, but it is possible that you may be reinfected with COVID-19 after already having the illness. Another common statement is COVID-19 vaccine will alter my DNA. None of the vaccines have been proven to alter a person's DNA. Both Pfizer and Moderna, they're considered mRNA vaccines, and these vaccines actually teach our cells to prevent the COVID-19 illness. Sorry, that's a typo there, not to prevent the COVID-19 vaccine, to prevent the COVID-19 illness from entering our cells. Johnson & Johnson, one of the newer vaccines, actually uses genetic material that teaches our cells to build protection against the COVID-19 virus. It is not a microchip, and is also proven to be safe for pregnant women as well. There's been recent studies that have shown that it is safe for pregnant women and those also breastfeeding as well, and that babies can also attain COVID-19 protection as well. Another common misperception is the vaccines contain cells from aborted fetuses. So this was kind of very controversial. The Catholic Church actually released a statement not too long ago, basically supporting the use of these vaccines and saying that vaccination is needed. The cells were not used or not obtained from aborted fetal tissue, particularly Johnson & Johnson. They were not used they were not obtaining aborted fetuses to produce these vaccines. In the past, there have been aborted fetuses that have been used to produce hepatitis A, rubella, and rabies back in the day, but that is not the case anymore. And the Johnson & Johnson vaccine itself does not contain any cells from the aborted fetuses. Another statement is the vaccine isn't that effective. If I get it, it won't protect me. It actually will. There's a study also by the CDC this spring that looked at least 4,000 essential healthcare workers in different states across the country. After their first dose of either the Moderna or the Pfizer vaccine, there was an 80% decreased risk of contracting COVID-19 infection. And then after their second dose of Moderna and Pfizer vaccine, there was a 90% decreased risk of getting COVID-19. So in summary, people of color or BIPOC communities, personally, some people don't like to use the word minority communities, but people of color, BIPOC communities, or Black, Indigenous people of color have been subjected to a lot of different health and healthcare iniquities, both past and present, which may or may not contribute to their hesitancy toward getting the vaccine. And like I mentioned before, it's not just Tuskegee. There are other current injustices and barriers that are affecting communities of color that we need to address, as well as in order to promote vaccine equity. And also COVID-19 has made a tremendous impact in our society, not only in our health, but also in our financial areas of life, and also in our mental areas as well. But overall, the summary is the COVID-19 vaccine is safe. And this is kind of the last slide is, trust me, I'm a doctor. And also I have a picture here as well of the mayor of Chicago, Mayor Lori Lightfoot. And I also just wanted this last slide about Henrietta Lacks and her descendants. You can contribute to their foundation. The two pictures on the right under Henrietta Lacks Foundation picture are her descendants. And then you have the pictures to the left. These are also descendants of the Tuskegee syphilis experiment, one of whom recently came out and supported getting the COVID-19 vaccine. Alrighty, are there any questions? I'm gonna stop sharing.
Thank you, Terrance. There's not a question in the chat yet, but we have some time. So folks, get yourself revved up. We want to hear those questions. But I have one for you. You had mentioned that you were going to speak a little bit about your own hesitancy and maybe your own process for getting vaccinated. So I'm really curious if you feel like sharing some more commentary on that.
Yeah, I was actually one of those kind of wait and see people. I was kind of hesitant in thinking that, oh, this vaccine has been produced so quickly, it's being put out so fast. I'll just kind of wait and see how others are doing once they get the vaccine. And I also thought, well, there haven't been studies done on the long-term side effects of the vaccine in the future. So that was my initial hesitation, but I took a step back and realized that this is bigger than me. This is not just for me. This is for protection of the community and mankind. Not only protecting myself, but protecting others against the COVID-19 vaccine. So it was kind of tough for me to do that and kind of look beyond myself, but I realized the bigger picture, that I don't want to get infected and I don't want anyone else that I care about or even the patients that I serve to get infected as well.
Thank you so much for sharing that. And I think these next questions, both Terrance and Janet, feel free to jump in and co-answer. I think you're both fully capable of doing that. This is a question from Audrey asking, it's a great question. So what will allow us to determine the various vaccines' length of immunity? Will we know this only after someone who's been vaccinated eventually becomes infected later down the road? Like, how do we know, since we're kind of watching science in real time here, when will we know about length of immunity? And how will we know that?
Yeah, that's a good question. I'll jump in first, and then Janet, you can add. Yeah, that's a very good question. It'll take time. We'll have to do more studies on people who have already been vaccinated to see how long their immunity lasts. So that's a very good question. It's kind of difficult to answer that. We'll just have to have more studies at this point. Janet, if you wanted to.
Yeah, I was going to add, Audrey, to the question, in regards to thinking about vaccine effectiveness, it's really trying to essentially trigger your body to mount antibodies. And so one for both just COVID infection as well as COVID vaccination, in regards to the studies to know how long does immunity last, we'll be actually tracking on a fairly regular basis the development or creation of your own body's antibodies and whether or not they are actually the protective antibodies to prevent infection. So that's, I think, one component. I mean, even before vaccination was available, people were trying to understand how long does someone's innate immunity last for when they've been infected with COVID. And so that's part of that recommendation currently is for people that have been infected with COVID to wait the 90 days. For most people within 3 months, they will still have some protection, but what's not 100% certain is how long does that protection actually last and for what age group or even population group. So that's going to be the ongoing aspect. And then there may be some different aspects in regards to the types of vaccine. The 3 that are available now, 2 of them have the very same technology that Terrance referred to, which was the messenger RNA. And then the Johnson & Johnson is utilizing a very common cold virus to actually deliver the kind of map, if you will, for your body to create the vaccine. But those are, understanding how does that mount that response is going to be just as important as well.
So I'm glad you brought up the 3 vaccines, and this is a question for both of you. So we have the Pfizer and Moderna mRNA vaccines, which have pretty much the same level of efficacy, although we're learning more and more about Pfizer, and we now know that Pfizer works for people under the age of 18. And I imagine we'll continue to learn more about all the vaccines, but Pfizer and Moderna have essentially the same level of efficacy. They're quite potent. And then we have Johnson & Johnson, which is also quite potent. All of these vaccines keep you from the hospital and keep you from dying, but they have different efficacy numbers attached to them. So how do you describe these 3 vaccines when you're talking to somebody? How do you talk about their different kind of what we've seen in studies versus how they're being rolled out in the real world?
What I will say, the most common question that I see from patients or lay people is, will I get COVID from the vaccine? And so I think that, the technology itself helps because there is no COVID infection or particles within any of these vaccines. So I think that's an important component to talk about. The other, in regards to some people may want to wait for one versus the other, some of it's just, they don't necessarily have any science to back it up. Not because it's wrong, but I think it's just personal kind of sentiments in terms of what they feel most comfortable with. And so I think another message in regards to which vaccine is available and which one you should do in general, because they're all considered very effective, even the Johnson & Johnson, despite the fact that they say, effectiveness is a little bit lower, it's, close to 80%. If you think about a vaccine in general, for any other infectious disease, what's considered successful is if it's 50% effective in regards to preventing the infection itself. So regardless of what type is out there, they're all extremely effective. And so whichever one is available to you is the one that you should take at that point in time. There are personal decisions. Some people want the single dose. Some people want the second dose. Some people may have, contraindications to getting one or the other. So it really should be whatever is the vaccine that's available at the time for you to get.
Thank you for that, Janet. Did you have anything you wanted to add to that, Terrance?
Yeah, I was just going to say I agree with what Janet said. And what I would tell my patients or to anyone is, I don't really care which one you get, just as long as you get the vaccine, because they're all essentially effective. This is, again, with my own hesitation, this is something you have to look at the bigger picture. There's been over 500,000 deaths already and still more affected by COVID-19. So it doesn't really matter which one you get, just as long as you get one vaccine, and they're all have been proven to be effective.
Yeah, and I think Janet's brought this up kind of tangentially, but the fact that Johnson & Johnson is a one and done, I think can be especially of interest to certain groups who, may be hard to come back for a second one, or taking time off work to go back for a second one. If you're a student or you're traveling, having to worry about a second shot can be kind of challenging, and one and done has some benefits in and of itself. So here's a really simple question from John Peller. What more can happen, and what more should happen in Chicago to increase vaccine access equity for BIPOC communities, particularly as larger and larger groups become eligible? So we've seen kind of the floodgates opening. We're now pretty much fully in 1C, which is quite a large category. And we'll be going beyond that probably sometime in April. So as more and more folks become eligible, how do we make sure we continue to focus on equity when the floodgates open?
I think part of it is education about the vaccine, and also having that presence in those communities that need it the most. So educating these people, educating these communities about the vaccine, providing the resources for education, and then also setting up a presence in those communities that need it the most, having these vaccine clinics in these communities on the south and west side, having mass COVID-19 vaccine drives in these communities. Because we know, at least I feel like, at least education, also lack of access is a big issue at this point, less so hesitancy. But yeah, if Janet, if you wanted to add anything or.
Yeah, I think a lot of it is twofold. I think, Terrance, exactly what you say is, having those conversations, the engagement of the different local community-based organizations as the credible messenger, as the trusted messenger, is extremely important. I was actually responding to another question in regards to the Englewood site specifically. To make that distinction. The Protect Chicago Plus, is intended to be kind of temporary clinics and special events to be able to increase that access. But I think the conversation now is really, how do you actually maintain that? To John Peller's point, how do we ensure that this is ongoing? And there's different conversations that are going on. I know today the city announced, I know right around Wrigley Field, they're announcing like a long-term mass vaccination site. I believe at Chicago State as well. They've identified, Kendall King College, which is another city college of Chicago, in Englewood, which they initially rolled out as an essential worker vaccination site. But I think, once we have a lot of those phases covered, we'll open up as a mass vaccination site. What has been shared with us that's important from the community is not so much that you have these pop-ups per se, but you have an identified static site that people know where to go. So once they are sensitized as to where they can get it, and as long as it's available, made available to them, people can show up. And then, for Mile Square specifically, I think there's a commitment from Mile Square, not just at the Englewood site, but all of the sites, to continue to provide vaccination, not only for their existing patient population, but also for the community at large in which they reside. So that's one of the things that we at UI Health are actually discussing. Right now we're in the midst of finishing up some of the first dose campaigns for Back of the Yards, as well Humboldt Park, Mile Square. We're on our second dose campaigns, but that transition in the next 3 weeks is going to be, how do we continue to make sure that that vaccine is available? And what's helped is that, while we created kind of a structured infrastructure, and for instance, the aldermen now are familiar, that makes it that much easier, because you learn that process, and trying to integrate that is going to be extremely important. I see Carmen Sanchez, you mentioned how, those homebound cannot get out. I think it takes a collective effort. There's a couple different methods that have gone out. There's strike teams, whether it's coming from an institution's perspective and dealing with their own patients that they know that are homebound and doing outreach. The city also has implemented some specific programs for people that are homebound. The other aspect is thinking about transportation. How can you actually provide transportation for people that may not be able to get it as well? So I think those are, a couple different movements that I know of that are actually going on right now.
Thank you. And we're right at the edge of the end here, but I want you both to be able to respond to this last question, and it's very appropriate. It's because, we all work in the HIV field. And so the question, there's a couple of questions regarding, have you seen any particular hesitation among people living with HIV around the vaccine and something specific to their HIV status? And is there anything that you recommend we can do, those of us who serve people living with HIV in case management and other roles, that we can be doing to help encourage vaccination uptake among people who are living with HIV? And both have to be brief. And it's a big question, but if you can be relatively brief, that would be great. Thank you.
I think the efforts in terms of case management should not be done with HIV alone. It needs to be combined with COVID and HIV. It's in many ways a natural kind of relationship to be able to have that conversation, is utilizing the case managers or the outreach workers to really have that conversation. There is no contraindication for someone getting the COVID vaccine if they happen to be HIV positive. I mean, very much so should be encouraged.
And Terrance, did you want to add anything?
Yeah, I mean, I agree with Janet, and it also has to be like a multidisciplinary approach with social workers, caseworkers, physicians, counselors, in order to educate clients, educate patients about the vaccine and that it is safe. So yeah, that's all I'll add for now.
And I'll just add, just last week, the CDC made official that people living with HIV should be included in phase 1C. So people with HIV have a higher risk of becoming seriously ill from COVID, in many cases due to the comorbidities and social determinants of health that put them at higher risk and higher vulnerability. So the CDC made that change a few weeks ago. The Chicago Department of Public Health put people living with HIV in 1C, and I think it's my understanding that the county has followed suit. I'm not sure where the state is on that, but hopefully the state is paying attention to what the CDC and the county and the city are saying. But with that, thank you all so much for being here today, for joining us. A huge thanks to Dr. Janet Lin and Dr. Terrance Weeden, who joined us on their lunch hour or their pre-lunch hour and shared so much important information and wisdom. We will be sharing their slides with you as well as the recording. So look for an email from me in the next day or so. And I hope to see you all at future grand rounds. So once again, thank you to our sponsors, MATEC, Humana, and AFC. And thank you all for showing up, being here, and doing the good work. We'll see you all soon. Bye for now.